Welcome back, everyone. In this part of the topic, we're going to talk about how we measure different lung volumes. So in terms of detailed learning objectives, they're to be able to define clinical measurements of pulmonary volume and capacity, define anatomical dead space and relate this space to alveolar ventilation, explain why matching ventilation and perfusion is important for efficient gas exchange in the lungs, be able to state the diagnostic tests they use for obstructive and restrictive lung disorders and state typical results found for each, and discuss the regulation of ventilation, including the homeostasis of blood gases and pH, and the primary factors that influence the respiratory control center and therefore control respiration. Spirometry measures volumes of air that move into and out of the respiratory system. And funnily enough, it uses a piece of equipment called a spirometer, which is what you're looking at here. We have a man hooked up to a spirometer, and this is attached to a computerized recording device. So it's kind of a diagnostic device that measures the amount of air you're able to breathe in and out and the time it takes you to exhale completely after you take a big deep breath. So now what we're going to do is we're going to look at a spirometry trace, and we're going to look at the different volumes of air that can be measured, and then how we use those volumes of air to calculate pulmonary. And so this is what we're looking at here, this trace that kind of repeats itself along the length of a computer screen. On the y-axis here, we have milliliters, and of course across here would be time, okay? Now you can see we've got all these different sort of names for different volumes that can be measured. So just as you're sitting there listening to me going on and on, what you're doing is you're taking tidal inspirations and expirations. So the tidal volume is abbreviated to VT or TV, and it is the amount of air inspired or expired with each quiet breath. So just in and out, in and out, and that at rest that's about half a litre or 500 mils. Now we also have the inspiratory reserve volume, which is this sort of peachy coloured one here, and this is the amount of air that can be inspired forcefully after inspiration of the tidal volume. So it's about 3 litres at rest or 3,000 mil. So just when you take a normal sort of tidal inspiration and then you breathe in as much as you possibly can, that's your inspiratory reserve volume. The expiratory reserve volume then is this one shown in green on this trace. And this is the amount of air that can be forcefully expired after you do a tidal expiration. Okay, so if you're just sitting there and you just do a tidal expiration and then you force out as much as you can, that's your expiratory reserve volume. This one can be measured as well, and it's about 1100 mils at rest. The residual volume, though, is this one in purple, okay? And this is the volume that's still remaining in the respiratory passages and lungs after the most forceful expiration. This one can't be measured with a spirometer. It's measured in other ways, but it is estimated at 1200 mils. And this is the air that keeps the alveoli open, and it can't be breathed out. Okay, so obviously when you do a forced expiratory reserve volume, your lungs are not going to collapse, and that's because of this residual volume. The minute respiratory volume, or the MRV, is the tidal volume times the respiratory rate. And obviously your respiratory rate is the number of breaths taken per minute, which at rest is about 12. So what you get then is, 6 litres per minute being the minute respiratory volume. Now the maximum voluntary ventilation is the maximum volume of air that can be breathed per minute by voluntary effort. So, it's going to increase, and the increase is in situations such as exercise. And that's what this is just showing you here. An example for a young 70-kilo male. You can see here that the maximum voluntary ventilation is increasing, kind of 20 times more than that when it's at rest. Okay, so we can use these inspiratory reserve volumes, tidal volumes, expiratory reserve volumes, and residual volumes to calculate pulmonary capacities. So a pulmonary capacity is the sum of 2 or more of these measured pulmonary volumes. Okay, we have an inspiratory capacity, which is your tidal volume plus your inspiratory reserve volume. Now you might have one of these inspiratory capacities, when you're about to dive into a swimming pool, because what it is the tidal inspiration plus that inspiratory reserve volume. The functional residual capacity then is the expiratory reserve volume plus that volume of air that's left in the lungs after you do an ERV. Okay? The vital capacity then, I'm sure many of you have heard of this one, is the sum of these three volumes, the tidal volume and the two reserve volumes. So this is the total amount of air that can be exhaled with effort after a maximum inspiration. So if you take in as much air as you possibly can and you blow it all out until you can't get any more out, that's your vital capacity. As we get older, our vital capacities decrease, and that's because our lungs and our muscles get a little bit less elastic, right? So we can't take in as much to blow out as much. And remember as well, everybody, that these volumes that are measured via spirometry change. They're obviously going to be different between tall people and small people and young people and older people, and there's also gender differences as well as exercise training differences too. Now the total lung capacity then is the sum of everything, right? So the sum of the inspiratory and expiratory reserve volumes, so the ERV and the IRV, plus the tidal and the residual volumes, and that is the maximum amount of air that the lungs can possibly hold. Just going back here to this functional residual capacity, this one can change, as well with disease, can actually increase, because with certain, pulmonary conditions or respiratory conditions such as emphysema, we have pooling of air in the lungs, so that sort of functional residual capacity can increase. Now there are other pulmonary capacities as well. You can have a forced vital capacity. Now the forced vital capacity is the amount of air expired in a forceful expiration after a maximal inspiration. So again, it's forced because you take in as much air as you possibly can and then you blow it out, as fast as you can. The FEV1 then is the forced expiratory volume in 1 second. There's a lot of these, capacities, right? But this one's important because it's the amount of air that you can expire in the first second of one of these, forced vital capacities. I'm going to come back to that in a minute because we do use this forced expiratory volume in 1 second, the FEV1, to diagnose what we call obstructive and restrictive pulmonary diseases. Now your FEV1 to FVC percentage should be normally around 80%. Again, I'm going to come back to that in a minute, but you should be able to get 80% of all that air that you took in, in a maximal inspiration, should be able to get 80% of all of that out in 1 second, right? The peak expiratory volume then, or the PEF, is the maximum speed of exhalation. Now, all of these capacities, can be used to sort of look at the health of the lungs and can be used to diagnose certain pulmonary conditions, which I'll get back to in a minute. But firstly, we're going to talk about dead space, okay? So there is dead space in the respiratory tract, so not all inspired air reaches the alveoli or undergoes gas exchange, right? We have something called anatomical dead space, which you can see in this figure here. It's all this air that's in the conducting zone, okay? And so it's that air that doesn't undergo gas exchange. You don't need to remember that it's 2 mils per kilo of body weight, but it's usually around 150 mils, right? We also have what we call alveolar dead space, right? And this is air that reached the alveoli, but it doesn't undergo gas exchange, right? So this shouldn't normally, occur. But when it does occur, if you have alveolar dead space, it's usually a sign of a clinical condition. So it's pathological. Now, alveolar ventilation is important because it's the volume of air that's actually available for gas exchange per minute. So what we have to consider here is the anatomical dead space from the previous slide, so that 150 mil in the conducting zone. We also have to consider, whether or not there is some value to this alveolar dead space. So normally this one should be 0, right? But in some clinical disorders, it's going to have a value. So the physiological dead space is the anatomical dead space plus the volume of any alveoli in which gas exchange is less than normal. So the physiological dead space should be 0 in healthy lungs, right? So what we do is for alveolar ventilation, we take the tidal volume, subtract that anatomical dead space from it, and times it by the breathing rate. Now, as I mentioned, spirometry can be used to diagnose respiratory disease, and there are 2 patterns of respiratory disease. These are obstructive and restrictive pulmonary disease. Now, with obstructive disease, a person will have restricted airflow, okay? And that might be due to bronchoconstriction of the bronchioles or mucus accumulation due to inflammation. Common examples of this are asthma and also COPD, which is a combination of emphysema and chronic bronchitis. Restrictive pulmonary disease, though, a person will have decreased lung volumes. So they're going to have, can't expand their lungs like people with normal lung function can. So there's going to be decreased lung volumes, and that might be due to decreased elasticity of the lungs, or it might be due to a problem expanding the chest wall during inhalation. And an example of that is pulmonary fibrosis. So we can use the forced vital capacity and the forced expiratory volume in 1 second to distinguish between the two. And I just want to talk a little bit about the FEV1 before I show you a couple of graphs that sort of help us to diagnose obstructive and restrictive. So with this forced expiratory volume, an individual with normal lung function can forcefully exhale about 83% of all of that air that they took in during the 1st second. So that's the FEV1. 94% should be exhaled, by the end of 2 seconds, and 97% then by the end of the FEV3, or by the end of 3 seconds. And this is what we're looking at here in terms of, measurement of forced vital capacity and FEV1 for people with normal lung function in green, an obstructive pattern there in blue, and a orangey colored there for a restrictive lung pattern. So what you can see here is people with normal lung function have that normal FVC, and then they have a normal FEV1, okay? And when we calculate that, the ratio of the forced expiratory volume in 1 second to the forced vital capacity, you can see that it should be, more than 80%, blown out in that 1st second. However, if you look at the blue curve here now, it's very, very different. So this will be an example of asthma. There is a normal or near normal FVC, so it's close to the, that normal one, but there's a much greater or a bigger reduction in the FEV1, right? And that makes sense because they have an obstruction in the airways, so they've got decreased airflow. So the ratio then of the FEV1 to FVC is less than 80%. And the lower that percentage is, then, the greater the obstruction. And then thirdly, we have restrictive disease like pulmonary fibrosis. And you can see here that there's a reduced FVC. That makes sense because these people have, problems expanding their lungs. So lung volumes are going to be low. They also have a reduced FEV1 as well, but then because all of the lung volumes are lower, when you calculate out the ratio of FEV1 to FVC, it kind of looks normal, or it can even be greater than 80%. Okay, so I'm going to stop here with these lung volumes and capacities. I just put together this little summary for you in terms of, that trace that you see with a spirometer, and then just kind of linking it all then to, the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, that residual volume there, the inspiratory capacity, then the functional residual capacity, the vital capacity, and then the total lung capacity. Briefly now looking at the ratio of ventilation to perfusion, and just sort of defining these terms again. Alveolar ventilation is airflow to the alveoli. Alveolar perfusion then is blood flow to the alveoli. Now, as you can well imagine, the efficiency of gas exchange can be maintained by the ability to match perfusion to ventilation. And they are usually, very kind of accurately matched so that, blood flowing through the pulmonary capillaries is properly oxygenated. However, diseases in either the cardiovascular system, so say not enough blood is getting to the alveoli, or let's say there's, not enough sort of oxygenated air entering the air in the alveoli. So either of those, can affect the ratio of alveolar ventilation to alveolar perfusion, and that can lead to things such as hypoxemia or, too low, abnormally low oxygen levels in the blood.